Okay, let's unpack this. Today we're diving deep into a virus that has haunted humanity for centuries. A name that evokes, well, frankly, primal fear. Rabies.
It really does.
It's a truly terrifying, almost universally fatal disease that, paradoxically, is entirely preventable.
That paradox is key, really.
Our mission here at the Deep Dive, as always, is to take complex medical information in this case, from a series of medical slides and a detailed research excerpt, and distill it into clear, actionable, and genuinely fascinating insights, specifically for you, our listener.
And this isn't just about, reciting facts off a page. Our goal for this deep dive is to guide you through not just what rabies is, but to meticulously explore how it silently operates within the body.
Right.
How medical science actually diagnoses it, which is quite clever, and most critically, to illuminate the absolutely vital life-saving role of prevention.
Prevention is everything here, it sounds like.
It truly is. And this exploration will show how understanding a specific pathogen like rabies connects to much broader fundamental public health principles and general infection control strategies, especially, within healthcare settings. It's about moving from that historical fear to informed, empowering action.
So let's start with the big picture. When we hear the word rabies, I think most of us immediately picture maybe a foaming at the mouth dog, something like that.
That's the classic image, yes.
But what exactly is rabies from a scientific and public health perspective? What's the core definition of this disease?
Well, at its heart, rabies is an acute, rapidly progressive, and highly fatal viral disease. Its primary target is the central nervous system, the CNS.
Okay.
It leads to a severe, devastating form of encephalitis, which is just inflammation of the brain itself. The specific viral culprit is a member of the lysovirus genus, known as lysovirus type 1.
Lysovirus type 1. Got it.
Now, what's absolutely crucial to grasp about rabies is its zoonotic nature.
Zoonotic.
Meaning it jumps from animals to humans. This isn't a human-to-human illness in the typical sense. It means it's fundamentally a disease of warm-blooded animals. While many species can become infected, the most significant reservoirs and transmitters to humans are often domestic animals like dogs and cats, but also wildlife such as bats, raccoons, skunks, and foxes.
So, the animals we might actually encounter.
Exactly. These are the creatures we most frequently encounter, making them key to understanding how this disease can, unfortunately, make the jump to humans.
It's definitely coming from animals, and that animal connection makes perfect sense. But how does that jump to humans typically happen? Is it something we need to worry about just being in the same room, or is it a much more direct kind of interaction?
It's a very specific transmission, actually, and that specificity is a major factor in why we can control it, thankfully. The overwhelming majority, and nearly all human rabies cases, occur via the bite of a rabid animal.
The bite.
When an infected animal bites, the virus, which is just teeming in its saliva, is directly inoculated into the human wound. That direct entry into the bloodstream or nervous tissue through a break in the skin is the primary pathway.
Makes sense.
Now, while this is the dominant route, it's incredibly important to highlight how exceptionally rare human-to-human transmission is.
Oh, good.
Yeah, in fact, it has only been definitively documented in a handful of isolated instances globally, primarily through corneal transplantation, where the donor was unknowingly infected.
Oh, okay. Corneal transplants, very specific.
Very specific. So, no, you won't catch rabies from casual contact, a handshake, or even a cough from another person. This isn't an airborne threat in human populations.
That's a relief for everyday interactions, certainly, but still a chilling thought about the bite. Are there any other less common, perhaps surprising ways the virus can be transmitted, even if they're not the primary concern?
There are indeed a few very rare non-bite exposures. These include exposure to aerosols, meaning fine airborne particles containing the virus, generated in very specific high-risk environments.
Yeah, where?
We're talking about highly controlled laboratories where the live virus is being studied, or perhaps in caves heavily populated by infected bats where the air can become saturated with viral particles from bat guano and urine.
Bat caves, right.
Even then, the risk is quite low and highly localized. And as I mentioned, corneal transplantation remains one of those very rare but documented rights for human-to-human transmission. But again, these are very much the exceptions to the rule, reinforcing that the bite of a rabid animal is the main concern you should be aware of in your daily life. Knowing this specificity is empowering because it means we know precisely where to focus our prevention efforts.
I'm struck by how specific that transmission is.
Yeah.
You're not typically catching this from a casual brush or even a sneeze, like you said. It's a very direct path, relying on that saliva-to-wound contact. That specificity must be a huge factor in how we approach prevention. Almost like a target for public health campaigns, isn't it?
Absolutely. It narrows the focus considerably.
Now, let's get microscopic for a bit. We're talking about a tiny, invisible enemy, yet it has such a distinct form, apparently. What does this bullet-shaped villain actually look like? And what makes it tick at a structural level? What's its basic blueprint?
Right. So when you visualize the rabies virus, you should think of a very distinct, almost iconic bullet shape.
A bullet, really?
Yes, literally looks like a tiny bullet under the electron microscope. It's quite small, measuring approximately 60 by 180 nanometers.
Which is incredibly tiny.
Incredibly tiny. A nanometer is a billionth of a meter. And importantly, it's an enveloped virus.
Enveloped.
That means it has a delicate outer fatty layer, or envelope, that it actually steals from the host cell it infects. It's almost like it puts on a cloak made from our own cells. And this envelope is crucial for helping it attach to and enter our own cells. Now, delving deeper into its internal structure, it possesses an internal protein core known as the nucleocapsid.
Okay.
This nucleocapsid has a helical symmetry, meaning it's coiled like a spring, and it carefully houses the virus's genetic blueprint. A single linear strand of RNA.
The instructions.
Think of this RNA as its tiny, very specific instruction manual for replication. Packed within this nucleocapsid alongside the viral RNA are key viral proteins. The L protein, which is an enzyme crucial for making copies of its genetic material.
The copier.
Exactly. Then the N protein, or nuclear protein, which helps package that RNA, and the NS protein, which assists the L protein. Together with the viral RNA, these form what's called the ribonucleoprotein, or RNP complex, essentially, the virus's inner working machinery.
The engine room, sort of.
You could think of it that way, yes. Encasing all of this is that outer lipid-containing bilayer envelope we mentioned, which is studded with transmembrane glycoprotein, or G protein spikes.
G protein spikes. Sounds important.
Oh, incredibly significant. In fact, this G protein is the only rabies virus protein that is known to induce virus-neutralizing antibodies.
The only one. Wow.
Yes, this makes it absolutely central to how our immune system can recognize and fight off the virus. It's the primary target for vaccine design, because by training our immune system to recognize and attack these G protein spikes, we can effectively block the virus from entering cells and causing disease.
So it's like finding the virus's unique ID tag.
Precisely. It's the vulnerability we exploit.
So if that G protein is the virus's crucial handshake, the way it gets in, what does that mean for our immune system's strategy? It sounds like we found the virus's unique ID, making it the perfect target for a vaccine, almost like a most wanted poster for our immune system to latch onto, isn't it?
That's precisely the insight. The G protein is the key identification marker. It tells our immune system this is rabies, target here, and that's why vaccines focus so heavily on training our bodies to produce antibodies specifically against that G protein.
Makes sense. And speaking of unique traits, is there just one kind of rabies virus that we're dealing with globally, or are there many variations that could complicate our defense strategy?
That's a great question. It's interesting. There is only a single antigenic type of rabies virus.
Just one type.
Antigenically speaking, yes. This means that, broadly speaking, our immune system generally recognizes all rabies viruses as one entity, and a vaccine designed against one strain typically protects against others, which is good news.
Definitely.
However, there are indeed strain differences. These are subtle genetic variations among viruses isolated from different animal species in various geographic areas. Think of it like different accents or dialects of the same language. They're all still the same language, but there are local nuances.
Okay, so minor variations.
We can distinguish these strains using very specific laboratory techniques, such as analyzing their nucleotide sequences, which can be useful for tracking outbreaks or understanding the epidemiology, where a particular outbreak might have originated. Now, let's talk about the virus's environmental resilience, because this is quite surprising and holds a key insight for prevention.
Okay. How tough is it?
Well, on one hand, the rabies virus is quite sensitive to common chemical and physical agents. Things like ethanol, iodine, basic soap, yes, simple soap, detergents, lipid solvents, Phenol, formalin, ultraviolet irradiation, sunlight, and even moderate heat can effectively inactivate it.
So, that's simple.
Yes. For example, 50 degrees Celsius for just 1 hour or 60 degrees Celsius for only 5 minutes will destroy it. This vulnerability to everyday disinfectants is something we powerfully leverage in immediate first aid, as we'll discuss.
Good to know.
But then, on the other hand, it demonstrates a surprising resistance to drying and cold. It can survive for weeks when refrigerated at 4 degrees Celsius, and for years when frozen at -70 degrees Celsius.
Lies.
Yes. This dual nature is quite remarkable. It's delicate enough to be washed away by soap, but tough enough to persist in specific, very cold conditions.
That duality is quite striking, isn't it? It's tough to kill with cold, allowing it to persist in specific conditions like a deep freeze, maybe in samples or something.
Or potentially in a carcass in cold weather, yes.
But surprisingly vulnerable to everyday things like simple soap and water. That's such a crucial detail for basic prevention. It means that washing a suspicious bite thoroughly can make a profound, potentially life-saving difference right at the outset.
Absolutely critical first step.
It's low-tech, but incredibly effective. Before we dive into exactly how it attacks the body and what that feels like, our sources introduce two fascinating, almost cryptic terms: street viruses and fixed viruses. These sound like something out of a spy novel.
They do have a certain ring to them.
What's the difference between them, and why does this distinction matter so much to our understanding of rabies and, crucially, to how we fight it?
This distinction is absolutely fundamental, actually, to both understanding the natural course of the disease and how medical science has learned to combat it. Let's break it down, because it's a perfect example of how studying a virus in the lab informs real-world solutions. Okay, first, we have street viruses. These are what we call freshly isolated rabies viruses, meaning they are found directly in nature in infected animals.
The wild type, essentially.
Exactly, the wild type. They are the actual viruses responsible for the naturally occurring disease in the wild. A key characteristic of street viruses is that they produce what are called Negri bodies. These are specific, distinctive inclusions, like tiny clusters found within the nerve cells of infected individuals.
Negri bodies, okay.
Finding these Negri bodies under a microscope is considered pathognomonic or uniquely indicative of rabies. Street viruses also have a strong tropism or attraction for salivary glands.
That's why the saliva is infectious.
Precisely. They readily infect and replicate there, which is why the saliva of infected animals becomes so highly infectious and how the disease is transmitted through bites. These are highly pathogenic, meaning they cause severe disease, and they're responsible for the typical incubation period in humans, which ranges from 1 to 3 months, or roughly 20 to 90 days, though it can vary significantly. Ultimately, these are the viruses that cause the full-blown, often fatal clinical disease. Now, in stark contrast, we have fixed viruses.
The fixed one.
These are rabies virus strains that have been isolated in a laboratory and then adapted through a process of serial intracerebral passage in laboratory animals like rabbits, or by growing them repeatedly in specific cell lines.
So tamed in the lab.
Essentially, yes. Through many, many passages, these viruses become attenuated or weakened in certain key aspects. A major difference is that fixed viruses do not produce Negri bodies, nor do they affect the salivary glands. Critically, fixed viruses are generally not pathogenic in the same way street viruses are. They won't cause the disease in a typical infection unless, they are improperly inactivated during production. They also have a much shorter incubation period in laboratory settings, typically only 4 to 6 days, because they're essentially pre-adapted to neural tissue.
Faster in the lab setting.
Right. And here's the most vital part of the distinction for public health. Fixed viruses are crucially used for vaccine production.
That's the key.
Yes. Their attenuated nature makes them safe and effective for stimulating an immune response in a person without causing the dangerous disease itself. So this distinction is vital for understanding not just the virus's unpredictable and terrifying behavior in nature, but how we've harnessed scientific understanding to attenuate and adapt it specifically for studying and combating the disease through vaccine development. It's a prime example of how deep scientific understanding of a pathogen's characteristics can be leveraged to create life-saving interventions for public health.
That's a fascinating pivot, taking something so deadly and intentionally fixing it, as they say, to become our defense.
Okay, so let's trace its terrifying path. You get bitten by a rabid animal, maybe a dog, a bat, or a raccoon. Then what happens inside the body? It's not like symptoms appear instantly, right? So what's that silent, insidious invasion process like before everything goes wrong?
That's right. It's often a very stealthy and insidious journey. The first thing to understand is the incubation period. This is the time from the moment of exposure, the bite, to the first appearance of symptoms.
And that varies a lot, you said.
It's remarkably variable. While it typically ranges from 20 to 90 days, it can be as short as 1 week if the bite is severe and close to the brain, or in very rare documented cases, it can stretch to a staggering 19 years.
19 years.
Extremely rare, but yes, documented. Several factors influence this period, including the severity of the exposure, the depth and number of bites, and critically, the location of the bite wound.
Location matters. Huge difference. Bites to the face, head, neck, and upper extremities are often associated with a significantly shorter incubation period because of their direct proximity to the central nervous system, giving the virus a shorter route to travel. Now, let's detail the precise step-by-step stages of how this virus spreads through your body, basically hijacking your own anatomy.
Okay, lay it out for us.
First, there's the inoculation. This is simply when the virus is introduced into your body, usually by the bite, and its saliva containing the virus enters the wound. Simple entry.
Step 1.
Step 2. There's a period of initial replication. For about 48 to 72 hours, the virus may replicate locally in the muscle or connective tissue right at the bite site.
Multiplying at the seam.
Exactly. During this very early stage, the virus has a specific affinity. It binds to nicotinic acetylcholine receptors on the postsynaptic membranes at the neuromuscular junction, or NMJ.
In NMJ, where nerves meet muscles.
Precisely. Think of the NMJ as the critical connection point, a gateway where your nerves communicate with your muscles. The virus essentially attaches to this gateway, preparing for its next move. From there, the virus begins its methodical, terrifying march via retrograde axonal transport.
Retrograde. Backwards.
Yes, backwards. This means it travels slowly but surely backwards along your peripheral nerves, away from the muscle and towards the dorsal root ganglia, which are clusters of nerve cells near the spinal cord, and then into the spinal cord itself.
Wow, using our own nerves as highways.
Exactly. This transport is incredibly efficient, essentially hijacking your own nervous system's highways, moving at a rate of approximately 2.5 centimeters per day. It's a silent invasion, exploiting your body's own communication lines.
2.5 centimeters a day. That's slow.
It is slow, which again explains the long incubation period. Once it successfully reaches the spinal cord, it moves into the stage of CNS dissemination. The brain rapidly becomes infected with the virus affecting critical areas such as the hippocampus.
Memory center.
Right. The brainstem.
Vital functions.
Yes. Breathing, heart rate. And the cerebellum, important for coordination. This rapid, widespread infection of the brain leads to the development of severe encephalitis and widespread neuron degeneration, which ultimately causes the severe, agonizing neurological symptoms we associate with full-blown rabies.
Okay, so it reaches the brain and spreads like wildfire.
Pretty much. Then finally, from the CNS, the virus doesn't just stay put in the brain. It undergoes what we call centrifugal spread.
Centrifugal, spreading outwards.
Exactly. Outwards from the central nervous system, traveling via ephemeral neurons to highly innervated sites throughout the body. These include the skin of the head and neck, which is why skin biopsies are useful for diagnosis. The retina and cornea of the eyes, the nasal mucosa, the adrenal medulla, renal parenchyma, and pancreatic acinar cells. And crucially, it also spreads to the salivary glands.
Back to the saliva, completing the cycle.
Yes. This is the key step that enables the virus to be shed in saliva, making the infected person or animal capable of transmitting the disease to another host through a bite. What's truly fascinating and deeply disturbing, here is how the virus masterfully leverages our own nervous system to travel. It's a slow, stealthy invasion that often goes completely undetected by the immune system during that extended incubation period.
So your body doesn't even know it's under attack for weeks or months?
Often, no. Your body isn't raising an alarm bell or mounting a defense during this critical window, which makes prevention so urgent once exposure occurs, there's no time to waste. It's also worth noting for diagnostic purposes that while the virus is almost invariably present in the cornea and facial skin due to their direct neural connection and proximity to the brain, it is generally not isolated from the blood of infected persons.
So a simple blood test won't find the virus itself?
Generally not, no, which is an important diagnostic nuance. We have to look elsewhere.
That detailed step-by-step journey through the nervous system is chilling. It's a slow-motion invasion that remains hidden for so long. So, After this silent, insidious journey, which as you said could take months or even years in rare cases, what are the actual signs and symptoms a person would experience once the disease finally takes hold? What does that unfolding horror actually look like in a human being?
That's the tragic part, because once these clinical signs appear, the prognosis becomes incredibly grim. The progression of rabies in humans typically unfolds in 4 distinct phases, each more devastating than the last. The first, as we've discussed, is the incubation period, which can last from 20 to 90 days, or sometimes, in very rare cases, much longer. During this time, the patient remains completely asymptomatic.
Feeling fine, no idea what's coming.
Exactly. The virus is making its slow, undetected journey to the CNS, and critically, it remains largely unrecognized by the immune system, offering no warning. Following that is the prodromal period, which typically lasts 2 to 10 days. This phase is characterized by non-specific symptoms, making it easily mistaken for other common illnesses.
Like the flu.
Very much like the flu initially. Patients might experience a mild fever, a general feeling of malaise, headache, loss of appetite, nausea, and vomiting. But here's a crucial symptom, one that's considered pathognomonic or uniquely indicative in about 50% of cases. Paresthesia.
Paresthesia, what's that?
It's an abnormal sensation like tingling, prickling, or numbness, or actual pain at the original inoculation site, the bite wound.
Back at the bite, even if it healed.
Yes. People might describe a burning or aching sensation right where they were bitten, even if the wound itself has long since healed. This is the virus affecting the local nerves there. Anxiety and increasing agitation can also begin to emerge as early features in this stage, hinting at the neurological turmoil to come.
A really specific warning sign if it occurs.
It is, if present. Next comes the acute neurologic period, lasting 2 to 7 days. This is where the clear, objective signs of CNS disease truly manifest, and it presents in 2 main forms.
Okay.
The first and most common is furious rabies, accounting for about 80% of cases.
Furious rabies, the classic image again.
Often, yes. Patients with furious rabies exhibit profound agitation, hyperactivity, and can display bizarre behavior, confusion, vivid hallucinations, and even combativeness, posing a risk to themselves and others. Seizures are also possible. Autonomic instability is very common.
Meaning the body's automatic systems go haywire.
Exactly. Leading to symptoms like excessive salivation, often called hypersalivation, which can be quite distressing, profuse sweating, and dangerous cardiac arrhythmias. And the hallmark symptoms of furious rabies, the ones people often associate with the disease, are hydrophobia and aerophobia.
Fear of water and air.
Yes. Hydrophobia is an intense, terrifying fear of water, where even the attempt to drink, the sight of water, or the sound of it being poured triggers severe, excruciatingly painful spasms in the throat and diaphragm. Similarly, aerophobia is a fear of drafts or air blown on the face, which can also trigger these agonizing spasms.
Horrifying.
The spasms are so violent that they prevent breathing, leading to intense fear and distress. It's truly awful. The second form, seen in about 20% of cases, is paralytic rabies, sometimes referred to as dumb rabies, because of the patient's quieter demeanor.
Paralytic, so paralysis.
Yes. This form is characterized by progressive paralysis from the very onset, often mimicking other neurological conditions like Guillain-Barré syndrome. The paralysis can be symmetric, generalized, or it can ascend through the body, eventually leading to full-body paralysis. Patients with paralytic rabies are typically quieter and less agitated than those with furious rabies, often appearing withdrawn. The delirium will progressively worsen, leading to stupor and eventual coma. The final grim stage is coma, which typically lasts from 0 to 14 days. The patient usually enters a coma within 10 days of the first symptom onset. This quickly leads to respiratory failure as the brain's control over breathing is lost, and ultimately death occurs within 14 days in most cases, even despite aggressive, intensive supportive care.
So fast, once symptoms really start.
Incredibly fast and devastating. It's incredibly important to emphasize that recovery is extremely rare, virtually unheard of once these clinical signs begin to appear. There are maybe a handful of survivors worldwide, ever. This highlights why prevention and immediate action are not just important, but absolutely critical for survival.
That transition from maybe just a subtle discomfort at the wound site to such dramatic and horrifying neurological symptoms is truly chilling. It really underscores why early action and understanding are so critical. Once those advanced symptoms are visible, it's almost universally too late.
That's the tragic reality.
It's also interesting to note that similar furious and dumb forms are seen in infected animals, particularly dogs, with symptom onset typically leading to their death within just 3 to 5 days, highlighting the rapid, devastating progression even in the animal reservoir.
Yes, the progression in animals is also very rapid once symptoms appear.
Given how rapidly this disease progresses once symptoms show and its near-fatal outcome, how do medical professionals actually diagnose it? What stands out to you as the most definitive or maybe the fastest methods, especially when every hour counts in such a time-sensitive situation?
You're absolutely right. Rapid and accurate diagnosis is crucial because of the dire prognosis once clinical symptoms appear. Laboratory diagnosis plays a critical role, not just for confirming an infection which is already likely too late, but even more importantly, for guiding post-exposure prophylaxis, the treatment given before symptoms arise, which is the only effective intervention.
So diagnosis helps confirm the need for PP or maybe rule it out.
Primarily confirming it, or confirming rabies in a suspected animal to guide human PP. It's also used practically post-mortem. Medical professionals can use a variety of specimens for testing, depending on whether the patient is alive or post-mortem. These include saliva, serum, cerebrospinal fluid, CSF.
Spinal fluid.
Yes. Also blood, urine, and skin biopsies, especially from the nape of the neck or face, as these areas are richly innervated and often show high viral presence. Post-mortem brain tissue is, of course, the most definitive sample.
Okay, lots of options.
Let's delve into the key diagnostic methods, focusing on what's most impactful. First, under microscopy. The classic method involves looking for Negri bodies.
Those things street virus produces.
Exactly. These are unique acidophilic intracytoplasmic neuronal inclusion bodies. Basically, distinct little structures inside the nerve cells. They are considered pathognomonic for rabies. If you see them, it's rabies.
Definitive if found.
When stained, they appear as round or oval, purplish-pink structures with smaller basophilic inner granules, almost like a target or bullseye within them. They are primarily found in neural tissues, particularly in the hippocampus and cerebellum. While highly indicative, they are only detectable in about 80% of human cases, meaning their absence does not definitively rule out rabies.
So not finding them doesn't mean you're clear.
Correct. It's not foolproof. A more common and critically a much faster microscopic method, especially for ante-mortem diagnosis while the patient is alive, is the direct fluorescent antibody, DFA test.
Biffy.
Much faster and highly specific. This method detects rabies virus antigens, the components of the virus itself, directly in clinical specimens. It works by using fluorescein-tagged monoclonal antibodies.
Glowing probes.
Essentially, yes. Tiny glowing probes that specifically bind directly to the viral antigens, making them visible under a fluorescent microscope. This test can be performed on corneal smears, skin biopsies, saliva, or brain tissue. For a diagnosis while the patient is still alive, skin biopsies and saliva are common choices, offering relatively quick results.
That sounds much more practical for a living patient.
It is very widely used. Moving to virus isolation, which involves trying to grow the virus in a lab. The virus can be isolated in cell cultures using established cell lines like WI38 or BHK21. However, the virus doesn't cause a very obvious cytopathic effect.
It doesn't visibly kill the cells much.
Right. It's subtle. So instead, the presence of the virus is often confirmed by detecting viral antigens using the DFA test within maybe 2 to 4 days. It's also noteworthy that the fixed virus strains used for vaccine production are adapted for optimal growth in these very cell cultures.
Useful for making vaccines, then?
Yes. Another method, historically very sensitive, is animal inoculation, typically involving mice.
Injecting mice. Sounds old school.
It is, but it's sensitive. Clinical specimens like brain tissue or saliva are meticulously inoculated intracerebrally into a group of laboratory mice. If infected, the mice will develop encephalitis and typically die within a week or 2. After their death, their brains are then examined for Negri bodies or viral antigens by the DFA test.
Sensitive but slow.
Exactly. Not ideal for rapid clinical decisions for a human patient, but very useful for confirming rabies in an animal, for instance. For serodiagnosis, we look for the body's immune response, specifically the antibodies it produces against the virus.
Checking the immune system's reaction.
Right. Rabies antibodies can be detected in both serum and cerebrospinal fluid, with typically high titers found in CSF, indicating a direct CNS infection. Tests like the Rapid Fluorescent Focus Inhibition Test, or RFAT, and ELISA are used for antibody detection. The presence of specific IgM antibodies, which indicate a more recent infection, or a fourfold or greater rise in IgG antibody titer in paired serum samples taken weeks apart, can confirm a recent primary infection or seroconversion.
Showing the body is reacting.
Exactly. Or, importantly, it can show that the vaccine is working, that the body is mounting the desired immune response after vaccination. Finally, we have molecular diagnosis, which is increasingly used and highly valuable for its speed and specificity. Polymerase chain reaction, PCR, is the overarching technique.
PCR, like for COVID.
Similar principle, yes, detecting the virus's genetic material. More specifically, nucleic acid sequence-based amplification, or NASBAR, performed on saliva and CSF, offers a remarkably rapid diagnosis, sometimes providing results as early as 2 days after symptom onset.
2 days. That's fast.
That speed is a profound game changer when every moment truly counts. Additionally, reverse transcription polymerase chain reaction, or RT-PCR, can amplify rabies virus RNA from fixed or unfixed brain tissue, saliva, and skin biopsy samples, often serving to confirm results from DFA tests or other methods with high precision.
It's incredible to consider how many different sophisticated ways medical science has developed to track this virus down, even after such a long and silent incubation period. And the speed of NASPIA for early diagnosis sounds like a genuine game changer when every hour truly counts.
It really is. The diagnostic toolbox is quite impressive now.
Knowing we have these tools is a remarkable testament to scientific ingenuity and how far we've come in fighting diseases like this. We've learned that once clinical signs appear, recovery is extremely rare, almost non-existent, making it a near 100% fatal disease. So given that terrifying reality, what does this all mean for treatment? Is there a cure for active rabies once those devastating symptoms develop?
This is perhaps the most sobering and critical aspect of rabies, and it bears repeating. Once clinical signs or symptoms of rabies develop, there is no specific antiviral agent that is useful, and the infection is, in virtually all documented cases, invariably fatal.
No cure, period.
No cure once symptoms start. Despite truly heroic advances in intensive care, complete recovery is extraordinarily rare. There are only a handful of documented cases globally, often with severe neurological deficits even if they survive. While supportive care, such as sedatives to relieve agitation and anxiety, maintaining hydration, and providing intensive cardiac and respiratory support, aims to manage complications and sustain life, it generally only prolongs the inevitable and patients succumb to the disease within days or a couple of weeks.
Just managing symptoms, not fighting the virus itself.
Exactly. So you can understand why the primary, indeed the only, effective focus of rabies management shifts entirely to prevention through prophylaxis. It's truly a race against time before those first symptoms emerge. For healthcare professionals, it also means universal precautions should always be taken with any patient contact, especially given the rapid progression and severity of the disease.
So prevention is truly the only effective battleground here. It is a cure, in effect. Let's break down the two main types of prophylaxis that are our strongest weapons against this deadly virus. Okay, PPP, post-exposure. If someone is suspected of being exposed to rabies, perhaps by a bite from a suspicious animal, what's the absolute first and most critical step they should take, even before they can get to a doctor or an emergency room? Is there something immediate that can make a difference?
Absolutely. And this is crucial for everyone listening to know. The very first and arguably most critical step in post-exposure prophylaxis, or PPP, is immediate and thorough local wound treatment.
Cleaning the wound.
But not just a quick rinse. This should begin right away, at home, even before you can get to a medical facility. The wound should be vigorously scrubbed with liberal amounts of soap and water for several minutes, ideally 10 to 15 minutes.
10 to 15 minutes. It's a long time.
It feels long, but it's vital. This simple mechanical act leverages the virus's known sensitivity to detergents, like we talked about with soap.
Right, the soap vulnerability.
And essentially washes away viral particles before they can gain a foothold in your nervous system. Think of it as literally washing the danger away. Following this scrubbing, chemical treatment with virucidal agents like alcohol, iodine, or povidone iodine should be applied if available.
Okay, scrub, then disinfect.
Yes. And a crucial clinical detail here is that suturing of the wound, stitching it closed, should generally be delayed if possible.
Don't stitch it up right away.
Yeah.
Why?
This is to prevent potentially sealing the virus into deeper tissues, which could inadvertently aid its spread towards the nerves. Of course, antibiotics to prevent bacterial infection and anti-tetanus procedures should also be administered as indicated to address other potential complications from the bite. But that initial wound care cannot be stressed enough. It's your immediate personal line of defense.
That immediate wound care is such a simple yet profoundly powerful first line of defense, leveraging the virus's vulnerability we talked about earlier to literally wash it away. It's an immediate practical step anyone can take in an emergency. But once that's done and you get to a doctor, what's the next critical step medically to prevent the virus from taking hold?
Exactly. Following that immediate wound care, passive immunization is the next critical component of PP, and it acts as an immediate short-term shield.
Passive immunization, getting antibodies directly.
Precisely. This involves administering hyperimmune serum, which provides immediate preformed antibodies to neutralize the virus right at the site before your body can mount its own immune response. Think of it as providing instant backup forces while your body's own army is still mobilizing.
Okay, what kind of serum?
The two main types are purified equine rabies immune globulin, or ERIG, which comes from horses, and human rabies immune globulin, or HRAG, which comes from human donors. HRAG is generally preferred due to fewer allergic reactions and greater safety profile. The typical dosage for HRAG is 20 international units per kilogram of body weight. The standard practice, and this is important, is to infiltrate as much of this dose as possible directly around the wound site itself.
Right into and around the bite.
Exactly. This provides highly concentrated, localized, immediate protection right where the virus was introduced. Any remaining amount of the dose is then given intramuscularly at a site distant from where the vaccine will be injected, usually in the gluteal muscle.
Why distant from the vaccine site?
Good question. It's ideally given either before or concurrently with the first dose of the rabies vaccine. It's absolutely crucial that HRAG is never given after vaccine administration has started or in the same limb, as the preformed antibodies could potentially interfere with the active, long-lasting immune response generated by the vaccine itself. This is about immediate bridge gap protection while the vaccine kicks in. Concurrently with that passive immunization, the anti-rabies vaccine is administered. Post-exposure vaccination is a highly successful and widely employed preventive measure, and it's what provides long-lasting active immunity by teaching your body to make its own antibodies.
Triggering your own defenses.
Yes. Modern cell culture vaccines, such as the human diploid cell vaccine, HDCV, purified chick embryo cell, PCEC vaccine, and purified vero cell rabies vaccine, PVRV, have largely replaced older, less safe neural tissue vaccines.
You mentioned those were risky.
They were. Those older versions, derived from animal brain tissue, were associated with significant adverse effects and neurological complications. The shift to these cell culture vaccines represents a monumental leap in safety and efficacy. These modern non-neural vaccines are remarkably effective and safe. They're typically administered as a series of 5 to 6 doses given on specific days following the exposure. Day 0, the day of exposure and first treatment, Day 3, Day 7, Day 14, Day 30, and optionally a final dose on Day 90.
That's quite a few shots over a month or two.
It is, and adherence is key. All doses are administered into the deltoid region of the arm. These modern vaccines provide protection for at least 5 years, and importantly, vaccine failures are extremely rare when immediate local treatment of the wound and a full, uninterrupted course of the cell culture vaccine are rigorously implemented.
So wash the wound, get the immune globulin, and get all the vaccine shots on schedule.
That's the trifecta for post-exposure success. The consistency of administration is paramount for the vaccine to stimulate a robust immune response in time.
It's incredible to think about the scientific progress from those early, riskier vaccines that sometimes cause neurological issues themselves to these highly effective and safe modern ones. It's truly a testament to decades of research and relentless public health efforts that we now have such a robust defense against a nearly universally fatal disease.
Absolutely. It's one of modern medicine's great success stories.
This is a story of science racing against a ticking clock and winning if you act fast enough. So that's what you do after a potential exposure. It's a race against time. But who should consider getting vaccinated before any potential exposure even happens? Who are the high-risk individuals for whom this proactive step, PIEP, is recommended? Essentially putting on their armor ahead of time.
Right. Pre-exposure prophylaxis, or PIEP, is specifically indicated for persons who are at a consistently high risk of contact with the rabies virus, meaning their occupations or regular activities put them in frequent potential exposure scenarios.
Like,
this group primarily includes laboratory workers who handle rabies virus, whether in research or diagnostic settings, as they might be exposed through spills or accidental needle sticks. It also critically includes individuals who work closely with animals, especially those who might come into contact with rabid animals.
That's Animal control.
Exactly. Veterinarians, veterinary technicians, animal control officers, wildlife rehabilitators, even spelunkers who explore bat-infested caves regularly.
Yeah, good explorers, right.
And also certain international travelers going to regions where rabies is highly endemic in dogs, for instance, and where access to prompt, reliable post-exposure treatment might be limited or uncertain. For these individuals, getting vaccinated proactively is a critical safety measure, almost an occupational necessity for some. The vaccine schedule for pre-exposure prophylaxis is simpler than the post-exposure regimen, which is nice. It consists of just 3 doses of vaccine given on day 0, day 7, and day 21 or 28.
3 shots. Much simpler.
Much simpler. To maintain a strong protective immune response over the long term, a booster dose is recommended after 1 year for some high-risk groups, and then regular boosters are advised perhaps every 5 years or so, often determined by checking antibody levels with a blood test. This ensures continuous protection for those in high-risk professions, maintaining their immunity shield. But it's important to state a crucial caveat, though. Pre-exposure prophylaxis does not eliminate the need for prompt post-exposure prophylaxis if an exposure to rabies actually occurs.
So even if you had the pre-exposure vaccination, if you get bitten, you still need treatment.
Absolutely. If someone who has received pre-exposure vaccination is bitten or exposed, they still need to seek immediate medical attention and get further treatment. What the pre-exposure vaccine does is significantly simplify and enhance the post-exposure treatment.
How does it simplify it?
For someone who's been pre-vaccinated, it generally eliminates the need for that passive immunization with rabies immune globulin, the HRIG, which can be logistically challenging and expensive to get sometimes. It also often reduces the number of vaccine doses required in the post-exposure regimen from 5 or 6 down to just 2 booster shots, typically given on day 0 and day 3.
Okay, so no immune globulin and fewer vaccine shots. That's a big difference.
It makes the subsequent urgent treatment far less complex, faster, and potentially more effective because your immune system is already primed. It buys you crucial time and peace of mind.
So it's not a get-out-of-jail-free card, as you might say,
Yeah.
but more like putting on your seatbelt before the car even starts moving. Doesn't mean you can drive recklessly, but it minimizes the risk and impact if something bad happens.
That's a perfect analogy.
It makes you significantly more prepared if an unfortunate exposure ever does happen. It buys you precious time and simplifies that urgent, life-saving response, which is huge when minutes can count.
Exactly right. It primes the pump, so to speak.
Okay, so while our sources didn't detail specific oral manifestations of rabies in humans, like unique dental symptoms you'd see in a patient's mouth, which seems unlikely anyway.
Right, not typically a direct dental presentation.
They definitely touch on broader implications for healthcare professionals, particularly for fields like dentistry, maybe because of the saliva connection. What insights can we draw here, even without direct dental symptoms, regarding general infection control and universal precautions that extend beyond rabies itself?
That's a crucial point, and it allows us to connect this specific deep dive on the rabies virus to overarching principles of general infection control and public health that apply across all healthcare settings, including, but certainly not limited to, dentistry. The lessons learned from understanding viruses like rabies have a much wider application. First, let's reiterate the transmission risk in its most fundamental sense. We know the rabies virus is excreted in the saliva of infected animals, which is the primary source of human infection through bites. Now, while direct human-to-human transmission of rabies is exceptionally rare, as we discussed.
Through saliva, you mean?
Right, even through saliva, it's rare between humans. However, dental professionals routinely work in an environment where they are in extremely close contact with patient saliva, blood, and other body fluids, often generating aerosols.
Yeah, drills and water sprays.
Exactly. This means they are inherently at risk of exposure to various transmissible pathogens, not just rabies, through contaminated blood, aerosols, and instruments. This foundational understanding of fluid-borne and aerosol transmission, even if the specific pathogen like rabies is rare in a clinical setting, profoundly shapes daily dental practice. This brings us directly to the critical importance of stringent infection control. Concerns about cross-infection were significantly heightened globally by the emergence of diseases like HIV/AIDS back in the 1980s.
That really changed things, didn't it?
It revolutionized infection control. This led to a massive increase in the regimentation and standardization of infection control practices across all of healthcare, including dentistry. This emphasis applies universally. Dental practitioners must be exceptionally well-versed in all aspects of infection control, from meticulous hand hygiene and rigorous instrument sterilization to the proper use and disposal of personal protective equipment, PPE, like gloves, masks, and eye protection.
The basics, but absolutely essential.
And this isn't just for their own implementation of safe practices, but also for effectively advising their team members and, crucially, for allaying patient fears. When a patient sees rigorous infection control protocols in action, it builds trust and confidence in the care they're receiving. Next, consider sharps injuries. Sharps or needle stick injuries represent a major and ever-present route of cross-infection in any medical or dental setting. Dental clinics are no exception, with the routine use of needles for local anesthesia.
Those long dental needles, yeah.
These types of injuries are well known to transmit blood-borne viruses like hepatitis B, hepatitis C, and HIV, which can survive outside the body for some time. Now, while rabies transmission through this specific route in a dental clinic from a human patient is noted as highly improbable.
Because it's not really in the blood, and human to human is rare anyway.
Correct, on both counts. But the general principles for managing sharps injuries and handling potentially infectious body fluids remain absolutely critical, regardless of the specific pathogen. A needle stick from any patient in any setting demands immediate and appropriate post-exposure management protocols. The habit has to be there. This leads us to reinforce the concept of standard infection control precautions, sometimes called universal precautions. This is a foundational principle in modern healthcare.
Treat everyone as potentially infectious.
Essentially, yes. It assumes that all patients are potential carriers of infectious diseases, and therefore, all body fluids, with the notable exception of sweat, are potentially infectious. This universal approach should always be the norm in dental practice, and indeed in all clinical practice. You treat every patient and every procedure with the same high level of caution and protection, irrespective of their known medical history or apparent health, because you simply cannot know what pathogens might be present asymptomatically.
It's not personal, it's just safe practice.
Exactly. This isn't about distrusting a patient. It's about systematically eliminating pathways for disease transmission for everyone's safety, patient, and provider. Finally, we can frame this within the broader occupational hazard for healthcare professionals. Dental professionals are very much part of the wider healthcare community that needs to be prepared for both common and emerging infectious diseases. While specific occupational hazards from rabies aren't highlighted as a common daily risk for dentists, the broad concept of being exposed to transmissible pathogens from patients underscores the importance of stringent infection control measures across the board.
Preparedness for anything.
Right.
It's why a vaccination against certain infectious diseases, including hepatitis B, tetanus, poliomyelitis, and now increasingly influenza and COVID-19, is widely recommended, sometimes required, for clinical dental staff. It's about building a robust, multi-layered shield against a range of risks, ensuring safety for both practitioners and patients in every interaction. So if we connect this to the bigger picture, even though rabies itself might not be a common direct dental concern, the stringent infection control protocols learned from understanding the transmission of viruses like rabies and later, HIV and hepatitis are absolutely foundational for protecting both patients and practitioners from any transmissible disease.
The principles transfer.
Completely. It's a testament to how foundational knowledge in microbiology and immunology translates into everyday safety protocols that ultimately save lives and prevent illness, making every healthcare interaction safer and more trustworthy. It's a fantastic example of how foundational knowledge in microbiology and immunology, applied broadly and consistently, makes healthcare settings safer for everyone, from the patient in the chair to the dentist and their entire team. It truly transforms complex science into practical, life-saving habits.
Well said. Hashtag tag tag outro.
We've journeyed through the epidemiology, the distinctive bullet-shaped morphology, the terrifying stealthy pathogenesis, and the critical, often devastating clinical stages of rabies. We've dissected how it infiltrates the body and the harrowing symptoms it causes. But the most powerful, most actionable takeaway from this deep dive is clear. This is a disease where prevention isn't just better than cure when symptoms appear. Prevention is the cure, your only hope.
Absolutely. That cannot be emphasized enough. The effectiveness of modern post-exposure prophylaxis, that immediate, thorough wound care we stressed.
Soap and water.
Followed by the immediate bridging protection of passive immunity through immune globulin, and then a full, consistent course of highly effective, safe, modern vaccines truly makes the difference between life and death.
It works if you do it right and right away.
And let's not forget the importance of pre-exposure prophylaxis for high-risk individuals, which acts as that critical preparatory shield, simplifying any subsequent urgent treatment. All of this reinforces the broader lesson of universal precautions across healthcare, an understanding that should inform safety in every clinical interaction you encounter.
So what does this all mean for you listening? It means understanding the signs of rabies in animals, unusual aggression, paralysis, disorientation. It means exercising extreme caution in potential exposure situations, avoiding contact with wild or unfamiliar animals, especially if they seem sick or are behaving strangely.
Basic precautions go a long way.
And crucially, knowing that quick, informed action washing that wound immediately, seeking medical attention without delay can make all the difference in a truly life or death scenario. It empowers you with vital knowledge that can protect yourself and those around you, turning fear into informed preparedness.
And maybe a final thought to leave you with. Consider how the historical terror and near 100% fatality rate of rabies once symptoms appear profoundly drove humanity's understanding of viral diseases. It wasn't just a threat, it became a powerful catalyst.
Pushing science forward out of necessity.
Precisely. It dramatically accelerated the development of highly effective preventative medicine, particularly vaccines, setting precedents for vaccine development and public health interventions that we benefit from today against countless other diseases. This knowledge, born from deep understanding and absolute necessity, ultimately empowers us to live safely alongside a truly formidable pathogen, armed with science rather than just fear.
Thank you for joining us on this deep dive into the rabies virus. We hope you feel more informed and empowered. Until next time, stay curious and stay safe.